Hi. Okay. Good morning, everyone. We're back here at Breakfast FOM. I've been told that this is the second session of 2021 at Breakfast at OM. So we are fortunate today to have Dr. Nadia Fareeda to present to us on COVID imaging from eyes AI. Dr. Nadia Fareeda is a senior lecturer at the Biomedical Imaging Department of Faculty of Medicine. She has been with us since medical school, and now she's one of our outstanding academic staff. We have been in our second year of COVID pandemic, and we know now that it's in our third wave, and we've had our challenges with clinical management of the COVID patients, and one of the important management of the COVID patients or clinical treatment is recognizing the imaging findings on imaging from chest X-ray to CT scan. So without wasting any more time, let's us begin our session with Dr. Nadia Fareeda on her lecture entitled From Eyes to AI in COVID Imaging.
Thanks, Prof. Kat. It's a pleasure to be with everyone today. Although I'm surrounded by four walls, I know I've got a lot of company virtually. So let's get started. COVID imaging from what we can see with our naked eyes. Oh, sorry. I have to share. Okay, now can everybody see my screen?
Yes, you're on.
Okay, so thanks, Prof. Kat. Then we'll get started now from COVID. Let's talk about COVID imaging from what we can see with our naked eyes to what we can see with superhuman eyes using artificial intelligence. So let's get started. Imaging is, as you can see, really we're part of this jigsaw puzzle that makes up the healthcare system. We work hand in hand with the clinical side, lab side, public health services, all with a common goal to provide the best healthcare service for our patients, and in this context, for our patients with COVID-19. So the first question when it comes to imaging in COVID-19 is, when do you need to image these patients? The KKM guidelines say that for stages 1 to 4, chest X-ray should be done at baseline and repeated when the patient deteriorates. For patients in stage 5, those critically ill ones, it's as per the ICU protocol. And the UMMC guidelines mirror this as well. What about in the international arena? So the Fleshner Society, which is basically an international multidisciplinary society concentrating on thoracic imaging. So the Fleshner Society came up with guidelines on when to image patients for COVID-19. So consider imaging if it's going to be useful to establish a diagnosis, guide your management, triage, or assess the therapy that is being given to these patients. But also remember that anytime you image these patients, they're being exposed to radiation. And when you have to move patients and there's more healthcare to patient and patient contact, there's always a risk of cross-infection between patient to patient and patient to healthcare worker. Another thing, a few things to consider are the availability of PPE, because whenever a procedure or an examination is done for patients, we have to use appropriate PPE, and especially in the context of CT scans, when a patient with COVID-19 is imaged, this involves a lot of cleaning of the machine, of the room, of the pathway, and this definitely will result in machine downtime. So is this going to affect the care of your non-COVID patients? These are all points to consider. Once you've decided that, yes, you need to image your patient, then the next question is, with what? What imaging? Do you do a CT or do you do an X-ray? So both of these modalities have their pros and cons. Chest X-rays are readily available, it's cheap, and very importantly, it's portable. It can be done at the patient's bedside. You don't have to move these patients. But in early and mild diseases, chest x-rays are insensitive. You may not pick up things. What about CT? CT answers the questions that chest x-ray can't. So it's sensitive. It can provide you information to consider an alternative diagnosis and also to detect pulmonary embolism. But you have to move your patients to the scanner, and you have to clean the room, clean the machine. So there's significant downtime there. Ultimately, it's a clinical decision to image or not. What imaging modality is the best in that situation? In our current local climate, most of the COVID patients get chest x-rays first. If there's a clinical deterioration, they get serial chest x-rays. If there's a severe deterioration where they suspect PE or they need better imaging, then these patients are then subjected to CT scans. So once you've done some imaging, obviously you need to know what COVID looks like. So there was a landmark paper published by Wong et al. From Hong Kong very early on, sometime in March 2020. So it was a landmark paper, somewhat, like what the Twin Towers is a landmark in the KL geography. So what they found is that COVID typically presents with bilateral peripheral consolidation or ground glass changes. That's the typical chest x-ray findings for COVID. What did we find? Our UMMC experience, as we reported in our mini review here, found findings which were in line with internationally reported findings on chest x-ray. So this is a 72-year-old man who came to our doors, and he had chest x-ray and unfortunately deteriorated and had a CT. So we can compare this chest x-ray and CT, which was done on the same day. He had these typical peripheral consolidations marked with the black arrow, which you can see confer with what we saw on the CT, and also these indistinct opacities in both lower lobes marked with the black boxes on the X-ray, which were also seen as ground glass changes on the CT. These are serial images of a patient who unfortunately deteriorated. So he came in initially with some indistinct opacities in the peripheral regions of both lungs on the chest X-ray, which then became more solid on a subsequent chest X-ray done 2 days later. And because of clinical deterioration, he had a CT, which was done 2 days after the second chest X-ray, and it showed a mixture of consolidation and ground glass changes in both lung fields, predominantly at the peripheries. Besides that, we also have seen reticular changes. So, and you can see in this blown up image, this patient had reticular changes in both lung bases, more so at the right lower zone, and you can see that clearly in this blown up image. And this patient had a CT scan subsequently, and you can see that on the CT, you see these areas of ground glass changes with reticular or reticulations or septal thickening, which are the changes that we see on the chest X-ray. And also he had consolidation. So, these ground glass changes with septal thickening is what we call crazy paving. We like to give names that are exciting so that we can actually remember them better. So another set of images, C and D here, show again the very typical peripheral consolidation here on the right lung, which we see on the CT, and these indistinct opacities on the left lung, which are also seen on the CT. So it's a mixture of consolidation, and ground glass changes. Those are the most common features, but in more advanced diseases, and sometimes patients have superimposed infections or complications due to barotrauma or just the disease progression, they can also have less common features, which we see in this patient here. He has developed a cavitating lesion, and you can see that that it is communicating with an airway on the CT. So, so he has developed a cavitating lesion, less common. So just a recap, the typical features are bilateral peripheral basal consolidation, but they can also get atypical features like pleural effusion, cavitation, and nodules, and so on. What about CT? CT can see whatever chest X-ray can see and more. So if we saw all that bilateral peripheral consolidation and ground glass on chest X-ray, certainly we can see it on CT, which with much better clarity. So in this patient, we demonstrate bilateral changes marked by these red arrows in both lungs, when you can see that they are basically ground glass and with some posterior predilection, peripheral predilection, and they tend to involve the lower lobes, although it is not seen well in this particular slice. Interestingly, in these areas of ground glass changes, the vessels are more prominent, and we refer to that as vascular enlargement or engorgement within the areas of ground glass, which is quite typical of COVID-19. Besides those very common findings on CT, which have been reported in more than 70% of cases, we also see other changes such as these reticulations or septal thickening, giving rise to this crazy paving pattern, and areas of consolidation in these arrowheads here, and some areas of consolidation are surrounded by ground glass changes. So it looks a bit like a halo of ground glass around this focal consolidation. Patients also get bronchiectasis, and when the disease is severe, it doesn't just stay in the peripheries and bases, it goes everywhere. So these are changes seen in about 10 to 70% of cases. Less than that are things like pleural effusions, which you can see in this patient is a very small effusion. So it's unlikely that you'll be able to see this on chest X-ray. Patients also can get pulmonary thromboembolism, as we see this filling defect within the pulmonary artery branch. So just a recap. On CT, the most common features which are seen in more than 70% of patients are, as we have mentioned, bilateral, peripheral, posterior, basal, ground glass changes with vascular engorgement. Consolidations tend to happen in about 50%, so they fall in the intermediate range. They also have crazy paving, halo sign, and septal thickening in this range of 10 to 70%, and less commonly seen are cavitation, nodes, effusion, and so on. So after all this imaging, can we use it to triage our patients? Can we provide more than just a report? Can we be a bit predictive, perhaps? See, with these kind of images, would the patients fall into the severe category or the mild category? So papers have been published looking at chest X-rays and CTs for purposes of triaging patients. And the Italians came up with a Brexia score system, which was developed specifically for COVID. And in Hong Kong, they tried then to adapt the real scoring system and to see whether higher scores were related to worse clinical features. And it roughly translated, but there was a lot of there were some issues because some of the findings were a bit subjective and scoring systems were a bit subjective. CTs, so there's more research on CT usage in triaging patients. There have been a few scoring systems such as the CTSS, the total severity score, and the chest CT score, which is similar to the total severity score. And they have attempted to establish thresholds or cutoffs whereby scores above a certain level are associated with worse clinical manifestation. So back to that question, are they useful? CTs, yes, it's promising because the features, the findings are very specific, and by a proper quantified way of reporting, we can have a very standardized reporting system, which is which can be used in different centers and will be useful. Chest X-rays, are they useful? Not so much. Why? Because the features that we see are often mild, and thus the scoring can be a bit subjective. So this is based on our eyes. What do we see? Yes, we can recognize patterns of common features and less common features of chest X-ray and of COVID-19 on chest X-ray and CT, but they are often not specific and not conclusive. So do we stop there? Obviously not. What do? We have a problem. We have a goal. We want better, faster, more accurate reporting. We also know the resources that we have. We have open access data sets, we have open access network designs which are available for anyone to tap and develop algorithms. And this has resulted in many deep learning tools, machine learning, where using CT images and also using chest X-ray images to help in establishing a diagnosis of COVID-19 or not based on these images. These are supplementary tools. They're not designed to replace RT-PCR. It's just to increase confidence in reporting. So artificial intelligence in COVID-19. So one quite remarkable paper by Lee et al., they used CT. So they developed this AI based on over 3,000 images. They divided the images into two sets, one to train the system and one to test the system. So once they trained the system and developed the system, which they called CovNet, then they went out and set out to test this CovNet deep learning tool on an independent set of images. And they tested the performance and did some statistical analysis to assess the confidence of performance of their neural network. So basically what they did was they piggybacked on neural networks that was already proven, and what they did was they used this thing called ResNet 50, which is quite, in layman's term, like an artificial brain that is able to detect features, and then they summarized the most activated, the most common features, and they fed it into this software, and they generated probability scores, and they tested it. The usual tests that are done for these neural networks are sensitivity, specificity, and area under curve. For chest X-ray, Ostok et al. Developed a different model, which they called the dark COVID net. In a similar fashion, so they fed this algorithm, lots and lots of chest x-rays. They developed the neural network based on an already proven model, used it to on chest x-rays to extract features, and they trained this model to classify the x-rays into two systems, either two classifications, either COVID or not, or nothing, no findings, or in a little bit of a cleverer way, they tried to see whether this AI could tell whether it's COVID versus pneumonia or no findings. What did they see? So both of them, Oster and Lee, found that the sensitivity and specificity for detecting COVID per exam was high, more than 80%. And there is another paper by this Abbasian Ardakani, which looked out at a whole lot of these convolutional neural networks that have already been developed in light of COVID-19. And they found that, that the best performance was by this model called ResNet 101 and exception. And not surprising, they found that it outperformed radiologists. So what do we see? With eyes, we can see patterns in COVID-19 chest x-rays and with CT. With AI, we can use it as a potential auxiliary diagnostic tool. And with everyone bringing their expertise to the table, with clinicians, engineers, and lab people, and all lab experts, and computer science, and there are far too many people to explicitly mention one by one. With all of us bringing expertise to the table, hopefully there will be some light at the end of this tunnel. Thank you.
Thank you so much, Dr. Oh, sorry. Right. Okay. Thank you so much, Dr. Nadia Fareeda. That was a very refreshing and interesting lecture from eyes to artificial intelligence. I hope our audience, we have about 140 attendees today. Okay, that is very refreshing. I realize that there are, do we have any questions? We can post any questions, and Dr. Nadia will be happy to enlighten our audience. All right, we have a first question coming from Yu Quen Chan. Dr. Yu, do we have the resources to do the same? I'm sorry, to do the, is this resources to do artificial intelligence? Yeah. I gather it is that.
Yeah, well, we do have some resources, but we are training models on a research, for research purposes now. It's not so much, it's not integrated into clinical practice. So we do have resources for training models. And we are actually trying, we are also a player in this game. We are also working and seeing what we can contribute in this AI, in the field of AI in COVID.
Thank you, Dr. Nadia. I hope that satisfy the Dr. Yu on the question. Do we have the next question? Yes. Hi, Dr. Nadia. Can we exclude COVID in normal chest radiographs?
No, certainly not. Because patients, chest X-ray for one thing is not sensitive, and patients with mild symptoms may have normal chest X-ray. So it's not to replace RT-PCR. It's a supplementary tool.
Thank you. And that is all right. Dr. Dave, coming from Dr. Dave, questions. So AI could perform better than radiologists in diagnosis if we have a checklist official way to report. Will it improve our accuracy?
Yes, that's why standardized reporting has been explored, especially for CT, because by having a full checklist, we will tend to miss less and we'll be more explicit in the way we report. But of course, it is more time consuming, so it's a balance.
Thank you. Coming from Dr. Yu again, why can't we extend it into clinical practice?
I think the models are all they're being tested, but like the one by Oster, they actually presented their findings back to the clinicians and to get the clinicians feedback on whether they agreed with the model or not. So if we want to implement AI, we need to give it back to humans, give it back to clinicians or experts in this field, see whether it makes sense. And if it does, then yes, we can include it. And I suppose it's not very far off in the future that we will be working hand in hand with AI.
All right, brilliant. Do we have any more questions coming?
I think there are a few
I'm not
questions in
sure
the
whether
chat
we have
box.
the time. I think I'm looking at the chat box. Hang on. We have answered, there were 4 questions. We have answered all of them.
I saw a Prof Ng ask, when will UMMC start implementing AI? When? I don't know the answer to that, Prof.
Oh,
When will we implement AI? I think we need to be open to the fact that humans have limitations and we need to have some computer-aided diagnosis. So
all right. Nadia, do you see any more questions?
Yeah, we have one from Ko. Should we perform Hrct in all patients diagnosed with COVID? Well, actually, it depends. Again, like what Fleischner's Society recommended. It's a judgment call. If you have the facilities and there's no significant downtime, then your threshold, perhaps not all patients, but perhaps we can lower the threshold and do Hrct for more patients with COVID-19, even with maybe mild or moderate disease. But if if your resources are limited, then you need to prioritize your machines and your resources for patients who need it more. That means patients with more severe illness. And at the same time, we also have to remember that we have non-COVID patients. So we have to remember that not to neglect them and have to ensure that their care is protected as well during this pandemic. So Hrct depends on your resources. AP and lateral view of the chest X-ray, there's no literature specifically on lateral view. If you notice the paper by the Italians and the Hong Kong and Korea and all that, they all talk about AP. So I do not know of any added benefit of a lateral view. So far, it's only frontal. I don't see any more.
No,
questions.
sorry about that. I think I missed those questions because they put it in the chat box instead of the Q&A.
Correct.
Anyway, a host, do we have any more time? It's almost.
I think you can take one last question. There's one from Prof Azim in the box, Q&A box.
Wait, Prof Azim, where is it? Is it in the chat box?
The
Q&A.
Q&A. Nadia, do you see it?
I have it. So related to the checklist question earlier, are there known CT or chest X-ray scoring systems for the diagnosis of COVID pneumonia? Yes, the answer is yes. There are scoring systems for both CT and chest X-rays, and these have been tested out. The CT ones have better validity.
All right, I think you've answered that question.
Yep.
I think if anybody else who has any more burning questions, you can post them to Dr. Nadia at her UMMC mail. I think it's in the poster that was distributed earlier. Anyway, any last words, Dr. Nadia? Thank you very much for the very interesting talk. I think we understand more about COVID imaging than before. And I hope the audience and the participants today will have benefited as well.
Thank you. Thank you, everyone.
Okay, yeah, I shall sign off. Thank you very much.
Thank you. Bye.